بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا ونبينا محمد الهادي الأمين. برحب بحضراتكم جميعا في اللقاء العلمي الثاني لمستشفى صحة قسم الأشعة بمستشفى صحة الافتراضي. ده نشاط تدريبي بتقوم به قسم الأشعة بالمستشفى صحة الافتراضي بوزارة الصحة لتبادل خبرات وعرض بعض الحالات المميزة يقوم بها استشاري أشعة متعاقدين مع المستشفى صحة مشكورين. والنهارده هيبقى اللقاء العلمي الثاني إن شاء الله. إحنا لقاءنا دوريا كل شهر، غالبا بيبقى الأسبوع الثاني من الشهر الميلادي. فجاء في مناسبة طيبة بمناسبة فوز المنتخب الصقور السعودي أمس على منتخب الأرجنتين، وده كان شيء أسعدنا جميعا. إن مفيش شيء اسمه مستحيل أبدا مع التدريب ومع التطوير ومع التعليم ومع الإدارة الجيدة. ممكن تحقق أي نتائج حتى لو كانت مستحيلة بعد فضل الله سبحانه وتعالى والتوكل عليه. فإن شاء الله يعني بادرة طيبة جدا وبداية موفقة إن شاء الله تستمر بإذن الله، والفوز والسداد دائما والنجاح دائما وأبدا إن شاء الله. إحنا معنا اليوم سعادة الدكتور عبد الله صالح الدوسري، هو استشاري الأشعة بمدينة الملك فهد الطبية، كونسلتنت راديولوجيست، سب سبيشاليتي أبدومينال إيمجينج. مشكور. هو جهز لنا حالات مميزة اليوم إن شاء الله، وهيكون مع حضراتكم هنعرض الحالات ويبقى في ديسكشن إن شاء الله بعد العرض. نرحب بكم جميعا ونرحب بسعادة الدكتور عبد الله ونشكره على هذا الجهد الكبير، يعني ما شاء الله، وإصراره على تنفيذ اللقاء العلمي. فتفضل دكتور عبد الله، مع حضرتك المايك.
السلام عليكم دكتور محمد، شكرا جزيلا على الانترودكشن. ونبدأ بالبرزنتيشن أساس ما يداهم للوقت. The presentation will be around 25 minutes. I'll give probably 5 minutes at the end of the presentation for any questions or queries. Okay, so the way I will present it, I'll present a case, then multiple choices for possible answers, and we'll discuss which one is more likely and why. So this is the first one, and these are more images for the same patient. So if you look carefully, look at this patient had upper abdominal pain, which was chronic, and abnormal liver function test. But if you look at the CT scan, you look at the pancreas, it looks sausage shaped, meaning that the thickness of the tail is similar to the thickness of the body of the pancreas. So it's not the normal tapering that we see in the pancreas. In addition to that, the pancreas loses its classical fluffy outline. Instead, you see it like a straight outline. And if you look carefully, there's a hypodense rim around it, rim around it. And if you look at the delayed images, you can see also the hypodense rim. This is a rim of fibrous tissue. These features are usually seen in patients with autoimmune pancreatitis, which is a type of chronic pancreatitis. And they can have acute and chronic presentation. On top of that, if you look, the patient has a biliary stent with intrahepatic biliary dilatation. So on top of the autoimmune pancreatitis, he has some biliary disease. Autoimmune pancreatitis can happen alone or can happen in the setting of IgG4 disease. And if you see it in conjunction with other findings like inflammatory bowel disease, retroperitoneal fibrosis, renal abnormalities, lung abnormalities, biliary abnormalities, you have to think of the possibility of IgG4 disease, which was this case. So it's unlikely the biliary dilatation is very unlikely to be primary sclerosing cholangitis because that does not explain the pancreatic involvement. And usually they present with intrahepatic strictures rather than a central stricture. So IgG4 disease involves more the central ducts, while primary sclerosing cholangitis likes to or prefers to involves or almost always involves the intrahepatic bile ducts, and 90% of the time involves intra and extrahepatic bile ducts. It's unlikely to be pancreatic cancer because all of the pancreas is involved. It's not a localized mass. Rarely, pancreatic tumors involve the entire pancreas diffusely and doesn't explain the hypodensity around it. Cholangiocarcinoma can cause biliary ductal dilatation and can be central, known as a Klatskin tumor, but again, it doesn't really explain the presence of the pancreatic disease. So it's most likely to represent IgG4 disease with autoimmune pancreatitis and IgG biliary disease. So this is the MRI of the same patient, and if you look carefully, the signal intensity of the pancreas on T2 weighted images should be similar to the subcutaneous fat or similar to the normal liver. Sometimes the liver might be bright due to fatty infiltration or edema, but if the liver is normal, the pancreas should look like the liver on T2 weighted images. And on T1 weighted images without contrast, the pancreas should normally be higher than the liver on T1 weighted images. What we see here is bright T2 signal intensity of the pancreas, which corresponds to low T1 signal intensity of the pancreas, which indicates pancreatitis. On top of that, you see the biliary stricture. It's central, it's not peripheral, so it's not the classical presentation for patients with primary sclerosing cholangitis. So it's a central stricture rather than peripheral. Of course, if you see this alone, there's a long list of differentials, including Klatskin tumor, HIV cholangiopathy, ischemia, invasion by porta-hepatis disease like infection or metastasis. But in the setting of pancreatitis and biliary stricture, you have to think of IgG4 disease. Okay, that's another patient also with IgG4 disease. If you look at the pancreas, you lose the normal fluffy outline. Since you have a straight outline, you have kidney involvement. The kidney involvement in IgG4 disease can be focal or can be multifocal or even diffuse. And you have the involvement of the central ducts with multiple central strictures. This behavior does not fit primary sclerosing cholangitis. It's more of a because primary sclerosing cholangitis usually involves the more peripheral ducts rather than the central ducts. Now, I brought an example here of primary sclerosing cholangitis. Let me just stop here for a second. Okay, so this is a case of primary sclerosing cholangitis, just to compare it with the case of IgG4 biliary disease. Look at the strictures in primary sclerosing cholangitis. They look more peripheral and they have the beaded appearance, more peripheral beaded appearance, while in IgG4 disease, they are more central and they don't like to involve the peripheral ducts. So primary sclerosing cholangitis, IgG4 biliary disease. This is another patient that came with weight loss and fever. If you look at the CT scan, we have retroperitoneal mass with multiple lymph nodes. And if you look carefully at the liver, there's a focal liver lesion. On top of that, this is a subtle sign that we always need to look for is the pattern of folds in the small bowel. We know that the jejunum is in the left upper quadrant and the ileum is usually in the right lower quadrant. And the jejunum has more folds compared to the ileum. But if you look at this image here on the left side, if you look at the jejunal loops, they have less folds than normal. And the ileal loops have more folds than normal. So this is a reversal of the pattern of small bowel folds. This is usually seen in patients with celiac disease. And as you all know, celiac disease patients are more prone to develop lymphoma, and lymphoma can present like this with retroperitoneal masses and lymphadenopathy. So this is very suggestive of lymphoma in a patient with background of celiac disease. These patients usually have chronic diarrhea and weight loss. So reversal of pattern, jejunization of the ileum and ilealization of the jejunum with liver mass, retroperitoneal lymphadenopathy, and a small pleural effusion. You have to strongly consider lymphoma. It's unlikely to be Crohn's disease because Crohn's, as you know, it does involve the small bowel. It can be associated with primary sclerosing cholangitis, and cholangiocarcinoma, which can metastasize to the lymph nodes, but it doesn't really explain the distribution of the fold pattern here. There are no strictures, no fistulas, no abscesses. It's just reversal of patterns. It's unlikely to be vasculitis or angioedema. Because vasculitis usually if it involves the bowel, usually it presents with mural thickening and enhancement and increased density of the bowel wall. And they can sometimes present with what they call water hollow sign, which is you see enhancing mucosa, enhancing serosa, and edematous submucosa. But we don't see any of that here. So this is a classical case of celiac disease with lymphoma. Lymphoma, of course, can involve the bowel itself or can involve the other organs. Like in this case, it was involving the liver. But in some cases, it can involve lymphoma. It can involve the bowel. And whenever you see a case of bowel lymphoma, especially in the exam settings, always look for signs of celiac disease. And you need to mention if there are signs of celiac disease or no signs of celiac disease. It's an important negative in exams. So this is a patient that had bleeding per rectum and abnormal liver function test. And if you look carefully, there's this polypoid mass in the cecum and the ileocecal junction. The rest of the colon doesn't look grossly remarkable. And if you look at the biliary system, there are signs of mild intrahepatic bile duct dilatation. So what are the possibilities? Of course, this could be colon cancer with liver metastasis, which can cause biliary obstruction sometimes. It could be coexisting biliary disease with colon cancer. So let's look at the possible differentials and think what it could be. Could it be Crohn's disease? Yes, Crohn's disease can be associated with primary sclerosing cholangitis, although it is not as common as ulcerative colitis. But it doesn't really explain the polypoid mass. Usually, in Crohn's disease, we have strictures, we have thickening, we have vascular congestion, fat creeping, fistulas, abscesses. We don't usually see masses. So Crohn's is probably less likely here. Ulcerative colitis, yes, ulcerative colitis can be associated with increased risk of colon cancer, especially if it's pancolitis, and they can have primary sclerosing cholangitis. So that's probably the best answer here. Can it be familial edematous polyposis? Quite unlikely because there are no other polyps detectable on the CT scan, and it doesn't really explain the biliary dilatation in this case. Can it be celiac disease? Again, the fold distribution does not really favor celiac disease. It doesn't explain the biliary abnormalities, and the lesion in the colon does not fit with lymphoma. Of course, lymphoma can be polypoidal, but the other imaging findings don't really fit with celiac disease. So probably the best option in this case is ulcerative colitis. So the next patient. So yes, this is a patient. This is another patient with ulcerative colitis. We don't see a mass, but instead we see rectal wall thickening, vascular congestion, reactive lymph nodes, with signs of intrahepatic bile duct dilatation, not the frank dilatation that we like to see in celiac disease, but it is abnormal in a young patient. So differential diagnosis, of course, here is ulcerative colitis with primary sclerosing cholangitis, colon cancer with liver metastasis causing biliary abnormalities. Whenever you see signs of primary sclerosing cholangitis, look for the complications of primary sclerosing cholangitis, which include abscess formation, intraductal stones, cholangiocarcinoma, cirrhosis. These are the possible complications of long-standing primary sclerosing cholangitis. We don't see this here. Probably this is early disease. Okay. Somebody's saying there's no sound.
لا، الصوت واضح يا دكتور. لا هي بس في مشكلة عند الدكتورة بس. اتفضل.
طيب ماشي ممتاز. Okay. So next patient. This is a patient with abdominal distension and abdominal pain. If you look carefully, there are signs of dilatation of the proximal small bowel loops, and if you look carefully, there's this structure within the bowel, it looks like it has rings of calcification. It's predominantly low density. Okay, it's predominantly low density, but it has rings of calcification like onion peels. And if you look also at the gallbladder fossa, there's gas in the gallbladder fossa and gas also in the CBD. So if you combine all these findings, dilated small bowel, this structure looks like a gallstone, so we'll consider it as ectopic gallstone plus plus the pneumobilia. Okay. This triad is called regular triad and is usually seen in patients with gallstone ileus, which is whenever there's when you have a stone from the gallbladder penetrating to the duodenum and entering into the small bowel and causing small bowel obstruction. It's called gallstone ileus. We don't see it commonly nowadays because of the improvement in intervention and surgery and early diagnosis of these patients. They usually have surgery before they reach this stage. And usually the obstruction is at the terminal ileum. In this case, it was in the distal jejunum proximal ileum. Usually the obstruction we see in the distal ileum because that's the narrowest part. Okay, so this is probably gallstone ileus. So these are the possible differentials. Obstructed inguinal hernia. Of course, we don't see any inguinal hernia in this case. A volvulus, usually with volvulus you see swirling vessels at this, and closed loop obstruction. This is not a closed loop obstruction. It doesn't explain the pneumopedia and the presence of a gallstone here. And obstructive tumor, there are no obstructive tumor. The site of obstruction is not caused by a tumor, and it does really explain the pneumopedia. So this is gallstone ileus. This is the next patient. The patient was found to have a liver lesion on ultrasound and was sent for MRI. So if you look carefully at the lesion on the T2 weighted images, you see the lesion is predominantly low on T2 weighted images with linear areas of bright T2 signal intensity resembling membranes or lines within the lesion. The lesion is low on T1 weighted images and has no enhancement after contrast administration. If you look carefully at the CT, you see foci of calcification, faint foci of calcification in the periphery of the cyst. So what's the differential diagnosis? Differential diagnosis of a complex liver cyst is long. It includes hydatid cyst, mucinous cystic neoplasm, which was formerly known as biliary cystadenoma, biliary cystadenocarcinoma. Now we call it hepatic mucinous cystic neoplasm. But these usually have enhancement after contrast administration within the septi. Cystic metastasis, abscesses, necrotic tumors like necrotic cholangiocarcinomas or necrotic HCC, necrotic metastasis. These can cause complex cystic lesions, but all of these, they usually have enhancement, except hydatid cyst. Hydatid cyst, because it's a parasite, it doesn't really have any blood vessels from the host. It doesn't have any enhancement after contrast administration. That's one important way to differentiate neoplastic cysts from hydatid cysts. So it's most likely a hydatid cyst. It's unlikely to be biliary cystadenoma, or now it's known as hepatic mucinous cystic neoplasm, because these usually have enhancing septation and enhancing wall. It's not cystic metastasis, again, due to the lack of enhancement. The simple cysts usually have bright T2 signal intensity and very low T1 signal intensity, and they usually don't have these membranes within it. These membranes probably represent layers of the wall of the cyst. So this is a classical case of hydatid cyst. Now, this is another example of a complex hepatic cyst, just in contrast to the other cyst. If you look at the pre and post-contrast CT scan, you see the septation here in the pre-contrast, and in the post-contrast, there's enhancing in the septation. So this is unlikely to be a hydatid cyst. This is most likely a neoplastic cyst. It could be mucinous cystic neoplasm, cystic metastasis. It's very likely to be an abscess, but it could be because of the surrounding edema. Abscess is another differential in this case, and they can have enhancing septation. But this is not a hydatid cyst. There's another patient with a complex cystic lesion. If you look at the wall of the cyst, it's quite thick and heterogeneous. Thick and heterogeneous is differential diagnosis, of course. I don't think we should include the simple hydatid cyst. This is most likely neoplastic cysts, such as mucinocystic neoplasm, cystic metastasis. Of course, abscess can also have this morphology. Abscesses, initially, they can start as a focal semi-solid or solid lesion, especially at the early stages of cholangiohepatitis. With time, they can liquefy. And with the liquefaction, they can have multiple small cystic components. And these cystic components, they fuse together and form larger cystic components. And when they fuse together, they can present like this with one large cyst, and they can have surrounding edema. Anyhow, so biopsy was done for this lesion, turned out to be cystic cholangiocarcinoma. So don't forget to include cystic or necrotic metastasis in the differential of complex hepatic cyst. So this is a patient that presented to the emergency with history of chronic abdominal distension with acute exacerbation of pain. And if you look carefully, there are multiple foci of plaque-like calcification in the abdomen with an area of eggshell calcification in the right upper quadrant, area of heterogeneous calcification in the left upper quadrant. The abdomen itself, if you look, it has high density compared to the normal abdominal imaging paucity of the bowel gas. There's not much bowel gas that we like to see in these patients. So differential diagnosis is broad. It could be parasitic infection. It could be dermatomyositis, calcification in the skin. It could be peritoneal metastasis. In this case, it turned out to be extensive peritoneal hydatid cysts. So if you look at the liver, there are multiple cysts. This one is calcified. Probably that's the first one that happened to this patient. If you can see also the non-calcified membranes, and you see non-calcified cysts in the liver. If you look at the coronal images, there are innumerable peritoneal disseminated hydatid cysts. Probably that cyst in the right hepatic lobe ruptured into the peritoneum, which led to spread into the peritoneal cavity. Of course, rupture of hydatid cyst can be dangerous, can lead to an anaphylactic shock and death. That's why during surgery, they need to be very careful not to rupture the cyst. Sometimes they use hypertonic saline to eradicate the scoliosis before resection. They inject hypertonic saline to the cyst. They use sometimes Clorox, diluted Clorox. The detergent we use with clothes, they dilute it and inject it into the cyst to kill the scoliosis before resection to avoid peritoneal dissemination. So this poor lady refused surgery, and this because of the high risk associated with the surgery. So disseminated peritoneal hydatid cysts. Now, this is a patient who had weight loss and abdominal pain. If you look carefully, the left hepatic lobe, if you look first at the delayed phase or portovenous phase, the left hepatic lobe has an ill-defined area of low attenuation. If you compare it to the arterial phase, it corresponds to an area of increased arterial enhancement. There's thrombosis of the portal vein. It's clearly seen on the left side. There's ascites, and the rest of the liver, if you look at it, looks slightly nodular, concerning for chronic liver disease. So patients with chronic liver disease and ascites, and with this infiltrative lesion in the left hepatic lobe, you need to consider, number one, infiltrative HCC, because of the arterial hyperenhancement and the washout and the infiltrative nature. Infiltrative HCC commonly invade the portal vein. Alpha-fetoprotein in these patients is almost always sky high. So if you're in doubt, look at the alpha-fetoprotein. If it's normal, it's very unlikely to be infiltrative HCC. All cases of infiltrative HCC should have elevated alpha-fetoprotein. The other differential diagnosis, of course, is infiltrative metastasis, cholangiocarcinoma, cholangiohepatitis. They can give you this ill-defined arterial hyperenhancement, but the invasion of the portal vein, the arterial enhancement, and the washout, and the background of chronic liver disease are all highly suggestive of infiltrative HCC. So it's very unlikely to be cholangiocarcinoma. They're usually not hypervascular. This patient is hypervascular plus cholangiocarcinoma. does not usually invade the portal vein. Instead, they cause biliary dilatation and they can encase the portal vein. So cholangiocarcinoma is unlikely. Metastasis is possible, but with the presence of background cirrhosis, we need to put the differential diagnosis of metastasis low on the list. Lymphoma usually is not hypervascular in the liver. They can be infiltrative and they rarely involve the portal vein. So it's very unlikely to be a lymphoma. So also another example of infiltrative HCC, and probably we should stop here and give some space for questions. So look carefully at this case. This patient clearly has signs of chronic liver disease, caudate lobe hypertrophy, widening of the porta hepatis, nodular outline, ascites, portosystemic collaterals near the gastrohepatic ligament and gastric fundus. So clearly has chronic liver disease, but I don't see any focal lesion. No, not in the arterial phase or the portovenous phase. Of course, one important note here: always make sure that you are doing the proper protocol. The arterial phase, it should be late arterial phase, meaning that you should see contrast in the portal vein, but no contrast in the hepatic veins. So contrast in the portal vein and contrast in the hepatic artery is an indicator that you have a proper timing of the arterial phase for the liver. If you see contrast only in the hepatic artery, but no contrast in the portal vein, so if you see contrast in the hepatic artery, but no contrast in the portal vein, that means that your scan is too early and you can miss hypervascular lesions like hypervascular metastasis, focal nodular hyperplasia, hepatomas. It can be missed if you don't do a proper arterial phase. But in this case, we have a proper arterial phase, yet we don't see any lesions. But this patient had very high alpha-V2 protein level. So they decided to go for MRI. And here's the MRI of the patient. Now look, how big is the lesion? Look at the T2 weighted images. The lesion is more than big. It's quite infiltrative. It's causing mild dilatation of the bile ducts. And if you give it, look at the contrast enhancement, ill-defined arterial hyperenhancement, which corresponds to washout on the portovenous phase. So this is a classical case of infiltrative HCC, just to illustrate how difficult sometimes it can be on CT scans. So if the alpha-V2 protein is high, and they don't is very suspicious for cancer, and if you don't see anything on the CT scan to explain the elevated alpha-V2 protein, consider doing an MRI because you can miss large lesions like this. So this is another case of infiltrative HCC that was impossible to see on CT scan, even in retrospect, but very clearly seen on the MRI. I think with this case, we should conclude the presentation and open the ground or the floor for questions. So somebody's asking about more emphasis about the term of jejunization and ilealization. Okay, so let me go back to that case. So where is it? Yeah, here it is. So if you look carefully, as you know, the jejunum has much more number of folds compared to the ileum. Ileum has less folds. I don't remember the exact numbers, but we all know the pattern of jejunum. So this bowel loop looks like a normal jejunal loop, but it's not in the normal position. Jejunal loop should be up here in the left upper quadrant in the proximal small bowel. And this bowel loop looks like the ileum because it doesn't have any significant number of folds. But instead of being in the right lower quadrant, it's in the left upper quadrant. So we have the jejunum mimicking the ileum. We call this ilealization of the jejunum. And we have the ileum mimicking the jejunum. We call this jejunization of the ileum. So this is classically seen in patients with celiac disease, especially the patients who are not on proper treatment and they have chronic disease. Okay, so jejunization of the ileum, meaning that the ileum looks like the jejunum, and ilealization of the jejunum, meaning that the jejunum looks like the ileum. Okay, I hope that answers your question. Any more questions? I think, yeah, since we don't have any more, some infiltrative liver lesions with ascites and portal thrombus can be considered as Budd-Chiari disease. Well, but Chiari is usually associated with hepatic vein thrombosis, not portal vein thrombosis. So no, it's not in this case. The hepatic veins are patent. Okay, so portal vein invasion with infiltrative liver lesion, you should consider this as infiltrative HCC. It's not Budd-Chiari, Budd-Chiari hepatic vein thrombosis, and they can give you Christmas tree type of enhancement, heterogeneous enhancement in the arterial phase with flip-flop enhancement, meaning in Budd-Chiari you see areas enhancing in the arterial phase, and in the portovenous phase, the areas that were enhancing wash out, and the areas that were not enhancing retain contrast. Anyhow, so Budd-Chiari is portal vein, hepatic vein thrombosis, not portal vein thrombosis. I think we should conclude here, Dr. Hamad.
Yes, Doctor, تفضل.
Yeah, I think we should conclude here. So we can, I think, Dr. Hamad, we can continue this lecture in the future time, inshallah. I have a few more cases to show as well if they want.
شكرا دكتور عبد الله، وشكرا على هذه excellent presentation يعني. تمام. لو في أي استفسار من حضراتكم أو أسئلة قبل ما نغلق الميتينج. تمام دكتور، ما في أي أسئلة إن شاء الله.
ممتاز.
شكرا دكتور عبد الله، وإن شاء الله نلقاكم مرة أخرى اللقاء العلمي الثاني إن شاء الله منتصف شهر ديسمبر، وأجازة سعيدة لكم يا رب. شكرا دكتور عبد الله.
السلام عليكم.
شكرا دكتور.